Thank you, Jeff, and thank you for inviting me here today. And we're going to actually skip the patient satisfaction talk in interest of time. I'm going to go right to discussing our heads-up 3D surgery system that we have at Lay Clinic, and Jeff's talk is a perfect introduction to this. No financial disclosures. I'm particularly happy to be here because this was the weather in Boston last week, and the weather here is fantastic, so very excited to be here. So I'm going to be talking about the Alcon Ingenuity system. It's a heads-up surgical system, and giving my perspective, we've had the system at Lay Clinic for about 1 year now. So this is a heads-up surgery 3-dimensional system, and we operate using a 3D 4K monitor instead of microscope oculars. It can be used for both anterior and posterior surgery. The main system is a 3D camera that attaches where the oculars would normally go on the microscope, a 3D television screen, and then the surgeon assistants wear 3D glasses, so you're seeing everything in 3 dimensions on the screen. My initial impressions was a quick learning curve. It was after a couple cases I felt comfortable using the system. The image quality is quite good. You're able to do both anterior and posterior surgery, although there's a little bit of differences I'll go into later. You still need the microscope. So the only thing we're taking off of the microscope is the oculars. You still need the rest of the viewing system and microscope. It's a great teaching tool, and as Jeff mentioned, there's a more upright posture which can help with ergonomics. So I'm going to show this video. Oh, theoretically I'm going to show a video. Oh, there it is. It's not playing here. So this is me sitting upright, doing this case. This is a 25 gauge vitrectomy on a patient with complicated retinal detachment. This is our standard 25 gauge ports. You can see the infusion port there inferiorly, and then the other two ports. This is the standard ReSight wide view system, which goes along with our microscope, the same as we would normally do. And here I'm just doing a core vitrectomy. You may be able to see, it's probably hard to see, but up and to the left there's a retinal detachment with a retinal break. And so we're trying to remove the vitreous. However, this was somewhat challenging to get the hyaloid up. So we ended up putting Kenalog in the eye to basically stain or at least contrast where the vitreous was to help us remove it. So here you see the Kenalog going in and me elevating up the hyaloid, and in a minute you'll see removing the hyaloid with the vitreous cutter. And this is obviously crucial for retinal detachment surgery to help prevent redetachment or PVR. This patient actually had some pre-existing PVR. So here you can see the hyaloid being removed, and here we're draining over the break. And what we realized was this was a complex schisis detachment. So there's both a large outer break as well as a smaller inner break. And what I did here is try to drain, and then I elected to remove the inner retina and unroof the schisis to make it a single break in this area. And then I marked it with cautery to make sure that we could see it once we went to gas. So here I'm marking the break with cautery. Now there's inferior scarring or PVR, and I cannot remove this with one hand, so I wanted to do bimanual surgery. So I put in a chandelier light, and now using two 25 gauge end grasping forceps can grab that scar tissue down at the vitreous base and remove it. If I was trying to do this with one hand, it would pull on the thin retina and probably cause additional tears. So using the two forceps, I was able to remove this inferior PVR. Here I'm draining the subretinal fluid and going into air. The retina flattened very nicely, so we decided to leave air in and not do a scleral buckle. This is then doing laser around that break to make sure it's well sealed. And then at the end, we changed the air to C3F8, a long-acting gas tamponade, and then removed the cannula. Patient I saw last week, and they're doing very well. So the benefits of the 3D system, ergonomics is a large one. As Jeff mentioned, leaning over to the oculars, especially in these long, multiple hour surgeries, can be uncomfortable. This allows a more upright posture. One thing to think of, however, is there's one screen that's usually over the patient's knees, and if an assistant is sitting on the side of the patient, they would have to then turn their head to see the screen, or back up and look straight at the screen, but then it'd be hard to do scleral depression and other things for the assistant. Because of the increased gain on the camera, you can use much lower light levels during the surgery, sometimes 20 to 50% or even less. And this allows longer surgeries with safer levels of light. This is a great teaching platform. Everybody sees the same image, so if a trainee is doing surgery and you see that they're having trouble with the image, you can give them direct feedback, say move the microscope, move the viewing system, move the eye, change your light direction, because you're seeing the exact same thing they're seeing. And you can also use a pointer on the screen to point to things, say, why don't you start the membrane peel in this area, something like that. That can be very useful. The staff and assistants are more engaged because they can put 3D glasses on and see the exact same thing that you're seeing. However, if they're off to the side, the 3D effect decreases. I've shown the videos here in 2 dimensions, but you can display them in 3 dimensions if you have the correct projectors and the glasses. However, the files are quite large. They can be 20 gigabytes or larger. One exciting thing is that we will be able to integrate future technology in the system. For example, intraoperative OCT might be able to come over on a side screen and you can see that maybe a cross-section of the retina where you're going down with a forceps on intraoperative OCT. And then we currently do endoscopy, but that's on a separate screen. At some point that again can be integrated into a single 3-dimensional screen. One thing with this camera is you do get increased depth of field. Now, this can be very nice when you're, say, doing membrane peeling on the retina. However, it can be challenging. I also do cataract surgery. If you're doing a cataract or if you're suturing on the surface, sometimes the extended depth of field can really feel like the instrument's coming at you and the movements can be very large. One thing that you can do is change the aperture on the cameras, and as you go to a smaller aperture, you get increased depth of field, as we heard earlier today with refractive surgery. And if you open up the aperture, that will actually decrease some of this hyper depth of field and make cataract surgery a little bit easier. So future directions, there'll be imaging processing to help improve the view. One of these things that we're looking at now is color channels to maybe highlight different structures. Certain colors may show the vitreous better, others may show vitreous hemorrhage or make vitreous hemorrhage less visible if you're trying to see through it. Also, if you're staining the membrane with a green or blue dye, you might want to change the color channels. Everyone always asks about what about using virtual reality goggles, 3D goggles to do this surgery. Currently the latency is a little too long between you moving your hand and what you're seeing, and that would be very difficult in surgery, obviously. I expect this technology to improve. However, the other issue, obviously, if you're wearing goggles on your face, it would be very difficult to interact with the patient if they started moving, or to grab an instrument, or to see other things in the room. And then, as I mentioned, intraoperative OCT and endoscopy may be future directions. It's important to remember this is an emerging technology. The microscope was first invented in 1590, and operating microscopes came into wide use in the 50s. Whereas digital video cameras were in the 1980s, digital TVs only in the 2000s, this True Vision system was used for cataract surgery not until 2011 and for vitrectomy surgery in 2016. So this is a very early, very emerging technology, and we expect advances to keep continuing. So I want to thank you very much for inviting me here. Thank you.